I call on you, please just remind me your name and, what you're planning to do next year. Today we're gonna talk about high value care, and before I even get started, I'll just,
Yeah,
just say probably when I was a physician years ago, when I finished medical school. I would say. Okay, very good. Yeah, okay. Perfect. Okay. So, question: how much is the average cost of gas in Charlotte? Anybody want to take it? All right, $3. Okay. Nobody's gonna say $100, right? So yes. So why is it that?
it's the gas all the time.
Exactly. It's transparent. You use it every single day, right? Perfect. Okay. How much does the CBC cost? For me, say. Anything that's for E? No idea. Okay, right. So, the answer to this question we'll talk about is it depends, right? So depends on where you're getting it and what the means of it is. Very different, obviously. So are we talking about cost? I've seen this slide. Way back when I was in college, usually like 1 out of 5 dollars we spend in this country is due to healthcare, right? So why does this matter? So all these terms that I'm definitely not aware of and I don't now payments, all of these have gone up, right? And at the end of the day, we're spending a lot more on this and all the supplements. Okay. So this should not be a surprise to anybody, right? So on the x-axis, it tells you how much we're spending. Y-axis is how long we're living. There are some countries here like Turkey. They don't spend a lot. They're getting a lot. Life expectancy is 73. You've got some countries that Japan that don't spend a lot, but they live a long time, right? So more bang for your buck. And then you got this one country all the way to the right. Okay, we're spending a lot of money on healthcare, and we're not really getting a lot. Question is why? What is it? So, what do you want? Yeah.
Commodity.
Okay, yeah. So it is a commodity just like buying groceries, okay?
Yeah.
Reactive, okay. Yeah.
Business.
Okay, business-like, absolutely, yep. How efficient would you say it is? And not if anybody's ever spent even one time in emergency room. But complex, right? Fragmented, inefficient, variable, wasteful, very, very common. So, I'm just gonna put my take home slide as the beginning of this talk, right? So 30 cents of every dollar of this country is wasted. And what is waste mean, right? So essentially things that you're used for to get insufficient, that's not gonna help our people get needs. It be x-rays, the back pain, lab studies, cases, medications, referrals, all these things, right? So these are gonna help your people. So this is the big high ground about what causes waste, unnecessary services, the biggest cause. Order at the end of efficient. Everybody in this room be partly responsible for this bike, right? Hopefully, Nobody's committing fraud. Nobody's setting prices. It's all sometimes from there. So when you see an right here, we're about to be an intern. Game of Thrones, one of my favorite shows, right? So you guys are one man or one woman facing an onslaught of forces that are beyond your control, right? So how are you going to do anything to kind of fix this, right? So, and that's what we'll talk about. You guys are, everybody in this room actually does have a very important role in this. So how are you going to provide better care? So high value care. Has anybody ever talked about this? Is this discussed at all during medical school? I'm just curious. So it's heard about high value all the time, right? So when you think about what does value mean, value deals back. Colleges are now not just having a top after talking about you're getting. Finally, it's kind of basically value is how good care are you getting divided by how much very basic. When you think about value, we spend a lot, but we're not really getting a lot out of it. So to argue, we in this country are spent place and we're fixed to getting a Honda, right? So I drive a Honda, my wife drives a Honda, everyone in my family drives a Honda. There's nothing wrong with driving a Honda, right? But if you were spending enough of affordable toys to be getting maybe cloth seats and not even sunroof, maybe a little bit upset, and that's essentially where's the time. Okay, so value different things to different people, right? So if you are, if you were a doctor, right? What would value mean to you? To your patient, you don't want to think again. First value means to the physician. First point by name.
Not letting the patient die.
Okay, yeah, having a good outcome, right? Death is bad, right? Death is wrong with a very high cost, right? If you are a patient or a parent, what does value mean to you?
Like solutions?
Yeah, that's right. So your kid comes and it's softball field and they have a broken arm and you've been in for 14 hours, busy. Yeah, you're going to get a perfect outcome, fraction your news, but now you've been working the next day, you're sleep deprived. So in that case, they say, well, my value is not fantastic. Of course, if you were the CEO of our healthcare, of your idea of value may be completely different. So if you want to kind of tease this out, value means not just how the patient outcomes, but the patient experience divided by not just current cost, but downstream costs, right? So we talked about if you keep a kid in the hospital too long and jobs, now they're homeless more folks, they don't have transportation. And those are downstream costs that you should think about the transition costs perhaps we should. Okay, so value, having the numerator, but it's outcomes, you want to minimize harm, and you want to make the patient centered. Then we talked about essentially stop doing things that don't help. So people hear about value, right? It sometimes can have a very negative connotation, right? When people hear you want to practice high value, they may just think you don't want to spend any money on my patient, right? Or on my child, but that's not the case. So we do things all the time that have high cost, but have good value. So chemotherapy, right? Very effective, 90% cure rate in pediatrics, right? So we definitely believe in spending money on that, right? And then there are things that have low cost and low value. So albuterol for bronchiolitis, right? Albuterol does not really cost that much, has minimal harm, but if you keep repeating it 100,000 times across, multiple emergency rooms in the country, what you're going to get is low value, right? For those going in pediatrics, we love, being in this quadrant. There are some things that have very high value and very low cost. Vaccines work, despite what some people in the current administration may think, but vaccines are effective and they don't cost a lot. They're very high preventative. And what you don't want to do is be doing things with the low value I thought, right? So sedated MRI is for people come in with headache. That definitely is low value height. All right. So, true story. This happened to me, actually. 23-month-old comes in, cough, runny nose in 3 days. But you're having a lot of long intake, exercise. The vital signs that were documented in your name, like febrile, they're not getting a significant no distress, color, non respiration. But they documented bilateral. So, happened. What do you think happened next? We think this patient died. Albuterol, right? Okay, correct. What do you think after you give somebody with healthy lungs albuterol? What happens to male consent? If you miss that, it's not unlikely that your male consent will run, right? And then what do you think happened next? How about to an emergency? What is actually going to get? Correct, oxygen. And then now I've got a kid in your urgent care on oxygen. Where do they come? Emergency room. And then do they get admitted? Problem. Okay, exactly. And so that's exactly what happened, right? So this kid who really was documented as well appearing, got a chest x-ray, got oral steroids, got 3 dabs and 2 sets from 95 to 90%. And then got, the right of the questions to ponder, right? Did this child get high value care? No, okay, that's pretty obvious. Was this child overtreated? Yes. Were ineffective therapies used?
Yes.
Okay, correct. Now the last one, we ended up the discussion. Who wants to raise their hand? Who thinks that this child was harmed? Whether intentionally or not? Yeah, probably, right? So, yeah. So, talk about overdiagnosis. This is an example of overdiagnosis. Have you guys heard of this term before? Yes, okay. It's not misdiagnosis. This is, you made the right diagnosis, but it doesn't really matter for the state, right? So, you see this all the time, right? So, felt bacteremia, allergies, jaundice, all these things, right? So, yes, you made the diagnosis, but how much did you spend on making the diagnosis, and then did it really help the patient? So, one example, okay. So this is a kind of page from a vintage automobile. So who wants to look at how complicated this one is? Kind of, yeah. If you were driving a car 70 years ago, what are the things that your car is telling you? Speed, okay, very good. Yep. What else?
Gas.
Gas is important. Okay. What else? Oil temperature, and see that's air pressure, right? And then your odometer, right? Okay, so right. So if all those things are check, you know that you're probably gonna get to your destination. All right. So compare that to you driving down, let's say you've got a clinic, a medical school, and one of these things shows up, right? How are you gonna interpret this, right? If I don't even know what that means, right? Like if this thing comes on, right? Like what are you gonna do? So this was a true story. I think before my step 1 or step 2 exam in medical school, I had one of these things come on, and I didn't know what to do. I don't know whether I had to, pull over on the side of the road, call 911, and get a tow truck. I wasn't sure just to ignore it for 6 months, or just try to get it to pick up. So I ended up going to the Toyota dealership. I waited 6 hours. Before that, my gas cap was not on the site. That was not ideal, right? And they started getting a lot of money for that. So not ideal, right? So I didn't figure out the whole big part because how many times you print that and nothing know how to interpret, right? Is this important? What do you do with this? And you've seen so many times, like in on chips, so to speak, you get a lab test because you've done a shotgun approach, maybe necessary or not. And the more results you get back, the more you have to do. Distraction, complexity, you're gonna see this a lot as a health officer, right? So all the little checky boxes that you're gonna get by the outgoing team to follow up on for an overnight shift, the more unnecessary things that are left for you guys to do, the higher chance you're going to miss the important. And keep in mind, the lab tests order doesn't necessarily mean semantic. All right, so the 1990, we're doing a lot, right? That's what I'm thinking. So there are benefits, high value care. You're a healthcare administrator and you want to be the high value guru in your hospital, you're going to be like their favorite pilot. You're going to improve quality, improve safety, increase costs, and you would think we would be doing everything. The next thing is, we talked about the outcomes and how to improve outcomes. Why is healthcare so difficult? So think about that CBC analogy that I mentioned, right? So it's impossible to shop, right? Imagine you have right lower quadrant pain, middle of the night, that's sharp, and you don't know what to do. What do you do, right? You go to the room at night, you wait until the morning, you call your friends. It's very difficult for you to price like what the right thing to do to help you. Nice thing to say about how we price things, but healthcare and how we price it was described as payoff behind a veil of secrecy. How much things cost. Every year, healthcare consortiums and insurance companies meet behind closed doors. They set it at the table and the price of every service that is free, right? So it's not very transparent. So again, you ask something like how much does something cost? It's just who's asking, where do you want the service provided, where do you live, and then when do you want it, right? Like there's no way you would ever buy any other commodity like this. So have you guys ever seen Adam with everything on YouTube? Okay, you guys seen this video? Okay, I'll see if I can get the volume to work. I'm just gonna put a disclaimer, most of what he says is correct, all right? A lot of anger towards healthcare industry. Some of this is sensationalized, so taken with a grain of salt, and it is literally accurate.
Basically, you'll need a surprise.
Multiple stakeholders and set prices for things. The question is like, how much does it cost? That kind of depends on where you are together, right? So, there's different things called costs, there's charges, there's reimbursement, how much you go back, and then the price is actually how much does the end result indicate. So, this is one of the more interesting things I came across while I was preparing for this. Years ago, I studies. The key to figure out how much different things. What she did is she looked up the top 20 industries and each of them breaks on price. Or if they pick these two more, they all figure out. She said, and surprisingly, calling ahead when you ask the hospital, estimate what the final result would be, and then if anybody had a guess at way, like, so,
75 to 150,000.
okay, great. So tell me your name.
Yeah.
We want to do neurology.
Neurology.
Right, okay, so that's actually pretty good, okay? 10,000 to 125,000, okay? So a lot, but if we're talking that even when you want to prepare for elective surgery, it is impossible to do that. So how are we going to make you guys kind of better at increasing cost and value? So I think this is important. So there's different ways we teach learners, students, and residents. So there's a formal curriculum sitting in a conference room, right? That's one thing you learn thing. There's something called informed curriculum. So you guys actually do learn from talking to each other, their experiences. But there's something called the null curriculum, which is important, right? So if you are on chips or, on telemedicine and they're recording all these tests, and you ask your attending, like, how much would that cost? And I say something to like, it doesn't matter, they're not paying for it. If I don't even talk about cost at all, right? It's simply not talking about things, actually, negative effect by thinking what is 100%, right? Um, I can tell you that when I was in medical school as a residency, nobody talked about cost and that's frowned down upon because it conveyed that you were not typically for your paper. And I think this comes a long ways from. So why do we overtest, right? So there's a lot of different reasons. Okay, you guys have been on shifts with me. I order things that, a multitude of reasons. And why do I do that? Right? So, one thing you may say is, um, like, there's a lot of indecision, right? A lot of times you don't know what the right thing to do is. And yeah, we do order tests in that, right? How are we taught? So again, as a production, consider cost. How do we fix that? We change the culture. Um, Preemptive ordering, you've seen this a lot, right? Yes, you could do things stepwise in the emergency room and wait for the test to get back, but you also have issues with treatment. So a lot of times people just are like PD or on shift on a direct admission, we just test and sort of sort it out, that may that often pay by. One thing that you hear a lot is defensive medicine. So yes, you do order a lot for malpractice. One way to combat that is state medicine. We do know that states that have put in malpractice laws that defend physicians and not really change the documents. And probably the last one is, if you can talk to an anxious mom or dad, if we move the face, but what do you do when they are standing MRI or a GI consult? What do you do in that situation? Right? So, I think how we talk to people is important, right? So I'm not using language that's going to be happening for the X-ray. I'm not going to help your kid. All this then sometimes you set up a good fight, and so that sometimes you're not leaving your clinic or the hospital without getting your decision making. You've done this on hopefully multiple patients. So, what are some ways to help figure out and talk about where? Um, There have been studies where, as a resident, they put the cost of things into the EMR. And what that shown is honestly changed about resident capacity. That's not. There's a couple websites here. If you ever need to shop yourself or your family members, get your grade. You've all heard of GoodRx, game changer for patients. Their health consumers open to everybody, right? And healthcare. So just an example, right? This is Day of Health. If you need a number for yourself or your patient, it tells you where you saw the network or you saw the network, right? Surprisingly, if you stay in network for a lot of things, that might think as much as the dreaded $10,000 that fee. And then healthcare blue books. If you put in CBC, it tells you how much does the CBC cost, right? So there's a range between $17 and $121. No surprise, if you just are getting a screening CBC and go to a lab or down the street, it's going to be very cheap. If you come to Novant or Atrium to get admitted, that CBC is going to cost a lot for the patient. Okay, so again, take home point 30 cents of every test, medication. Last study you did. Everybody in this room are the primary drivers for healthcare costs. High value, one person said it's the right here at the right time at the right price. That's essentially how we define it. And in fact, we'll be better, just the people cost aware services. Any thoughts on that? Opinions, comments?
I kind of disagree with the second sentence. Medical providers are the main drivers.
Yeah.
So if the like, let's say the price of insulin went up 10 times, since like I don't know, 20 years ago, 10 years ago,
Yes.
on medical providers.
Right, yeah, yeah, so. That consultant going to see somebody and say, no, your PCP is doing a fantastic job. No, they're probably going to order more tests, they start more medications. So, all that medical providers play are still the largest segment in that pie chart. Any other thoughts or critiques? Yes.
They're encouraged to think of the worst case first, and oftentimes that that makes you want to order like the big tests. And how do you like balance, or like how do you combat that?
Yeah, so absolutely. So the question is, you guys are going to be starting out, right? And nobody here wants to intentionally miss a diagnosis, right? So there are, guidelines, right? So the purpose of guidelines is that they were finding that people were deviating from how to treat pneumonia or how to work up a DVT or a PE, right? So I think if you simply only do nothing but practice within the standard of care, that should kind of avert a lot of unnecessary ordering. And I would just say this has nothing to do with my talk, but there's probably no better person to kind of push the boundaries of why are we doing things, why are we, why has it always been done this way than you are, right? So you'll be surprised even 5 or 10 years after medical school graduation, you're going to be set in your ways, and you're going to treat pneumonia the exact same way. You're going to treat functional abdominal pain the exact same way, right? So, but there's no better time in your career than to ask, like, why are we doing things? Why are we ordering this test? Than the next couple of months, right? So, and I think it's very fair, right? A lot of the things that we've changed and how we practice medicine was caused by people asking, like, "Hey, this is dumb. Why do you want to order, corticosteroids on this bronchiolitic Dr. Bidwin, right?" So, and it's hard. It is hard because, right, your intentions were good. Nobody wants to miss something.
Difference in wasteful spending in academic centers versus non-academic centers?
That is that's a great question. I don't know the answer to that. I mean, my gut would tell me that if you are in a training facility, I mean, a lot of times you've seen interns, fellows may order tests before the attending even sees the patient. So it wouldn't surprise me that learning facilities are have higher costs. The charge master is interesting. The last thing I'll say is there was a law under the first Trump administration that every medical facility, whether you're staying in, Atrium or going elsewhere, should have a charge master for everybody from the public side to see how much things cost, right? When we've done this presentation and we've looked up the Atrium charge master, it is like a gobbledygook of characters, exclamation points. It makes no sense, right? So just because you're required to do something, nobody's holding healthcare organizations accountable for it, right? So that's the first issue. And the out of network thing is a big deal, right? So there was a story on the Today Show. This mom came into the hospital, delivered twins. One twin was born before midnight, and the other twin was delivered after midnight. And she got 2 separate bills because the before midnight physician was in network, and the after midnight was by an out of network physician. And there's no way you could prepare for this. Who would ever think about asking if their anesthesiologist for their C-section is at network when you're having a C-section? So these are big deals. They're sometimes sensationalized, but I feel like the only time we can change policy is by, putting these things on the news.